bathroom and void. It will not work. The bladder substitute does not contract. And so the first evening when you withdraw, you always withdraw the catheter in the morning. That's a general rule for every urologist, because the complication you want to deal during daytime, not when you sleep at home. So withdraw the catheter in the morning. In the evening, you make an in and out catheterism if the ultrasound doesn't work. And if he has a lot of residual, leave the catheter in overnight. Patient is tired, you are tired, then overnight you can take a rest, and next morning you try it again. If after 2-3 days it doesn't work, send him home with a catheter for 2-3 weeks. Instruct him how to rinse the bladder, maybe by aspirating, and you will try it again. I bet you, if you don't make a funnel-shaped outlet, he will be able to void. Perhaps not the first day, but it will come if you insist on it. Also make sure he has sterile urine. It must be sterile. It's a misconception to think in his bowel there are bacteria. Small bowel does not contain any E. coli, Klebsiella, Pseudomonas, whatever you want. Yes, anaerobics, but for that we give metronidazole. So the urine must be sterile. If the ileum is exposed to bacteria, it defends itself. And how can it defend itself? By producing mucus. If a patient has a lot of mucus, it's your fault because he doesn't have sterile urine. So don't say this is a stupid thing, these bladder substitutes are full of mucus. You're stupid if you don't detect the infection in time. But at least we will see. It always occurs also in our hands. But then it's a very important signal. Lot of mucus, must have an infection. And the second thing is, beside the mucus, the reservoir becomes hyperactive. And hyperactive means the patient becomes wet. We will see all this. I give you the proof in a short moment. Do with him also the sphincter training. Show him, again, do the digital. You cannot just say, do sphincter training. Or send him to the physiotherapist. They will do everything. They will train the abdominals, they will train the legs, I don't know what. But not what you need. So you have to do it yourself. Do a DRE, digital rectal exam. Now you tell the patient, now squeeze my finger. Yes, good. So the last 2-3 drops will not come out. Often it's the mucus that comes at the end. So after having voided, expel the urine. And this is typically the patient, he said, look, I go to the bathroom, I take my time, everything, I clean myself, I'm dry. I can walk around, but the first time when I sit down somewhere, come 2-3 drops. And the association, sitting down, that's stress incontinence, that's not sphincter failure. He compresses his bulbar urethra and expels the urine that is in there already for the last 20 minutes. So, if a patient complains about the few drops, his pad is quite often moist, and that's disturbing. Think about this. You will improve your results by 50%. Just this simple maneuver. But these are things you have to teach the patient proactively. Also, tell your patient to use an alarm clock at night and explain him why. Look, your own bladder, there were nerves, a lot of nerves. They went to the pelvic plexus running up over the seminal vesicle. Even the patient understands it very easily. That's number one. That's why the results are very different to radical prostatectomy patients who still have here the sensory fibers. But also, we do not have any neurofeedback to the brain. There's nothing that awakes you at night when it is full. You just have an overflowing continence. Fortunately, you have an overflowing continence. If not, the reservoir will burst. But you cannot expect to be awakened at the right time. And many patients tell you, I get up anyhow once or twice. Yes, but at the wrong time. You have to tell them you go 3 hours, and 6 hours after going to bed, you have to have an alarm clock. Then you go. And then it's up to you, the physician, during follow-up. He's always wet before he gets up the first time. What do? Has to set the alarm clock early. He's always wet before the second time, but he has almost nothing to void when he gets up the first time. Put the alarm clocks later. That's proactive management, and then you get these patients dry. And he explained to him everything, and now he should go home, and now he gets weak. tired, he had greyish appearance, loss of appetite, he has stomach burning, nauseated. Proton blockers. That's wrong. That's wrong. No proton blockers. Yes, that's good against stomach burning, but it just prevents the body to have the safety exit. It can no longer excrete the acidity by the kidneys, because the bowel reabsorbs the acidity. So Mother Nature is so clever. It says, well, then I produce the acidity here and throw it out. And if you block the production of gastric acid, you push the patient into acidosis. So no proton blockers. That's one thing we learned. Because when you have the symptoms of acidosis, you can first prove it with the venous blood gas analysis, but more important is to know why it happens, because, as I told you, the reservoir is reabsorbing the acidity. From pH 5 to pH 7 within 2 hours, without changing anything to the urine. No further urine in the reservoir. Within 2 hours, the acidity is gone. Out of the reservoir, double the dose. You go from 2 to 4 grams. And in some patients, you need to go up to 6 grams of sodium bicarbonate per day. And then they feel happy again. Other thing we must know also, that if the urine is hypoosmolar, within 2 hours you will have an isoosmolar state. More concentrated urine within 2 hours. How is this possible? Well, we must know, and that's namely the hospital like this, when you just drink a lot of water or tea, you have hypoosmolar urine. But this here is bowel, and the bowel always wants an isoosmolar milieu, because only under isosmolar condition it can start